Today, we're talking about advanced directives, and our speaker is Dr. Cyril Barch. He received his MD from the Medical College of Virginia and did his internship and residency in internal medicine at the University of Iowa. He's board certified in internal medicine and geriatrics. He practiced medicine in Eureka, California until 1990 before moving back to his home in Virginia. He practiced in Winchester, Virginia until retiring in 2019. Since his retirement, he has focused on promotion of advanced medical directives, first with Valley Health in Winchester and also with Blue Ridge Care. In addition to his work on advanced medical directives, Dr. Barch is active in the Winchester community, where he serves on the board of directors for the Winchester Rotary Club and as a board member of the New Eve Maternity Home. He's married to his wife, Jean, for 57 years and has 5 children and 5 grandchildren. So please help me welcome Dr. Barch to the podium. Thank you.
Thank you very much. Since retirement, I've kind of taken on advanced medical directives, and it comes from my experience of seeing people become ill, and then ill enough to be in the hospital, and then ill enough that they are really near death, and they've done no preparation for this. That leads to tremendous stress for the individual and, of course, for the family also. So for that reason, I have kind of taken this on as my duty, whatever word you want to put in there. I think it's very, very important. Do you all recognize any names? Nancy Cruzan or Karen Quinlan? Hands if you recognize any. Okay. I'm going to tell you just a bit about Nancy Cruzan. The stories are really both the same. Nancy lived in Missouri. She was age 23. She left home and was involved in an auto accident. Her cart flipped over. She was thrown 35 feet out of the car and landed on her head. She did not breathe for 20 minutes until the EMTs arrived. They were able to resuscitate her and got her to the hospital. But the bottom line is that her brain was severely damaged. She was never able to talk. She was never able to interact with anybody. So they were able to get her off a breathing machine fairly easily, but the issue that then arose was eating and drinking. She did have a tube placed. After, I believe it was 2 years, her parents petitioned the hospital to have the feeding tube removed. The hospital refused, and as you can guess, they went into the court system. In the courts, the parents, quote unquote, won at the first level. That is, there was an order that the hospital was allowed to remove the tube. The hospital appealed that. It went to the Missouri Supreme Court. And there the Supreme Court recognized that people have the right to refuse therapy. We can all decide what we want done or not done. But obviously, Nancy was not able to decide that. The parents, when they made their appeal at the Supreme Court, they did bring in a close friend of Nancy's who worked with the two young girls worked with disabled kids. And there was one child in there that was dependent on a feeding tube and had to be fed with syringes. That person came and testified before the state Supreme Court. And that gave the beginning opening for the judges to be able to realize, number one, we got a real problem here. Number two, anybody in the U.S., in any state, the underlying legal standard is that life is to be maintained. So if something happens to one of us, we're at Walmart, we're somewhere, EMTs will be called and resuscitation will be instituted. That is the gold standard. Everybody gets that. Well, the judges then listened to the friend, the young girl, and they said, basically, go back. One person was not enough to be able to say that Nancy, was really firm about this. She did not want extra things done. She did not want to be on life support. If she was unable to interact with people, she did not want to be maintained. So the judges said, find more people that can substantiate what the one person said. And indeed, the family, they did. They went back home. They found people that worked with Nancy. They found her close friends. Nancy would spend the night over at someone's house, and they would talk about all sorts of things. So the bottom line is the family was able to bring in a number of people that knew Nancy very intimately and could testify as to what she did and did not want. Based on that, it did go to the U.S. Supreme Court, and the court recognized, number one, you can decide. Number two, if you can't decide, they did recognize all of the friends of Nancy that came in and testified, and they accepted that as what Nancy would have wanted. And that is the beginning of how advanced medical directives got developed. That was in the court case was in 89, and in 1990, Congress passed a law to allow advanced medical directives. So that kind of, Nancy was before the fact. Now we are all able to do a document of sorts. So Nancy lived for 9 years unable to communicate. Hopefully that will prevent what Nancy went through, would prevent that for all of us. There is a way to prevent it, but you have to be active. When I say active, I mean you have to be proactive and do a document. So now we will move on. We're gonna tie some things together. So that is the basic background for why we're talking about advanced medical directives. So we don't end up in an intensive care unit for weeks and weeks, and the bottom line is you don't survive. Since I don't know your hospital system intimately, but hospitalists are now providing most of the hospital care, I think, across the United States. Our community has two groups. If one is owned and operated by the hospital, the other is an independent group. To be used by the independent group, your doctor has got to sign a contract with them. But in times past, when I first left medical school and went into training, I admitted all of my patients. I took care of them in the hospital. I took care of them at night. And that was the way. It wasn't that I was some great thing. That was the hospital system. Everybody did that. So over the last 15 years, what's happened is most primary care doctors have moved out of hospitals, no longer do that. And instead, they've been replaced by what are called hospitalists. They're typically family practice doctors, internist doctors. They typically work in shifts. In our community, they work a week on and a week off. On the week on, they either work a 12-hour day shift or a 12-hour night shift, one or the other. And then they're off for a week. And they do no outpatient care. So once you're in the hospital, you're ready to go home, they send you back to your primary care physician. If you get it in our hospital, Thursday is the day they change over, where your 1 week on ends and you go home. Point being is on Friday, there's a new shift that comes in. So if you get hospitalized Thursday afternoon or Thursday evening, you get Dr. A, and the following day, you're shifted over to Dr. B. If you have another problem midweek and they have to bring in one of the other physicians, you could end up seeing 2 or 3 different physicians in that same week hospital stay, where in times past you had the one guy or the one woman, whatever. But the point is hospital care has become very complicated. So we got a maze, and we got to find our way through it. So my purpose in talking about Nancy Cruzan and now the hospitalist is to give you just a little background of this maze here, because the way you navigate the maze is you fill out the Advanced Medical Directive, and that gives direction as to how to get through this thing. So what is an Advanced Medical Directive? It is a legal document. It allows you to pick a medical agent. You can decide what type of therapy you want. You don't. This does not have to be done through a lawyer. There's only 2 requirements. You got to be over the age of 18, and I think this audience easily qualifies. The other part, which is more difficult, is you got to be competent. Okay, what does competent mean? It means when your doctor sits down and explains, Ms. Jones, you got XYZ problem. And first, Ms. Jones understands the problem, and then the doctor begins to explain what the different alternatives are with therapy. So what does the document allow you to do? You can express your wishes regarding what type of medical therapy you want or what type of therapy you do not want. It helps to honor your preferences. I'm sure people here have already heard of folks that wanted a particular therapy. They didn't have their documents, they didn't communicate with the healthcare team, and they got much more care than what they wanted. So it also reduces family stress, and we'll talk a little more about that. So what is an advanced directive not? It is not a will. It only deals with you and your medical care. And it's used only at one point in time. If you are in a state where you don't understand what's going on, as long as you understand, the doctor does what you and the doctor figure out what's going to happen. So this becomes valid only in that one instance. So the will is how you deal with your property and stuff you own. So in North Carolina, there's multiple components to your Advanced Medical Directive. The first component is the healthcare power of attorney. That is the very, very important part of your document. The second is what's called the living will. In the state of North Carolina, you have a directive for a natural death, where ahead of time you can pick and choose types of therapies you want or do not want. You also, so that document you can identify what you want to use and what not to use. So this document is not mandatory. It has to be signed by you and 2 witnesses. It complements the healthcare power of attorney, and it does not override other documents. So this is where you can find your documents for your state. There are 2 other documents in North Carolina. There's one for mental health, and there's one, it's called a MOST document. The mental health would be specifically for people who have underlying mental health issues. They've been hospitalized before, they're on medication that allows them, before they're in the hospital, to pick and choose different things they may want done. This is a pretty specialized thing, and I'm not going to talk any more about it. I just want you to know it does exist. And the other was what's called the MOST form, and we're not going to talk about that either, but I just want you to have heard it. So what's the most important thing in what we've been talking about now for the last 5 minutes? The most important thing is the person you pick to be your medical agent. Now, there's a lot of names for medical agent, and don't worry about, I just picked that one arbitrarily, but it could be a power of attorney, a healthcare proxy, the healthcare power of attorney, a durable power of attorney, healthcare agent. Just pick whatever name is best for you, but then the real key is picking the person. So your medical agent, that person can be anybody, really. It could be your spouse, it could be a child, it could be your parent, it could be your next door neighbor, it could be your church pastor. The real key is, number one, you've got to tell that person. It would not be the first time where someone was never asked to be their medical agent, and the first thing they know is the phone rings at 2 o'clock in the morning, and it's an intensive care somewhere saying that Miss Jones is in the unit, and you, person on the phone, are the person they have designated to speak for them. So you've got to go and talk to that person. Not only talk, first you ask, would you be willing to do this for me? Once you've gotten that okay, then it's time to kind of explain what is most important to you at that point in time. And what I'm thinking is, I spoke to one gentleman, 82, an attorney, very bright guy, and asked him, what's most important to you at this point in life? And his answer was reading and listening to music. Those were the 2 things. So if you were his agent, and he fell and broke his hip and he got a bunch of pain medicine and he was confused and they're, trying to figure out, should we do surgery or should we not do surgery? Well, what did he tell you? He said the things he really wants to do is music and reading. Should we fix the hip? Yeah, we should fix the hip. What if he came in with abdominal pain and needed his gallbladder taken out? I think it would be fairly easy to say, yes, let's do that, because then he can go back and do the things he really likes to do. Another gentleman was in a nursing home, and when his answer to the question, he was bedbound. So the answer to the question he gave was, I want to watch sports on TV. He would just lay in his bed and all day long he would watch different sports programs. So if he was in the situation where he had a major stroke and could not communicate with people and could not be aware of what was around him, his medical agent would take what he said, max it to what's happened medically, and then try to answer questions about his therapy. It is helpful to have the agent living nearby. Usually you only choose one agent, but you can have alternate agents. The secondary agent would only fill in if the first one was not available. Why should all this matter to you? The hospitalist, like we talked about, doesn't know you. They have no relationship. They don't know what's important. They don't know what's happened to you in the past. They even may not have access to your medical records. So what can a medical agent do? They make choices for you about your medical care. They can refuse a medicine. They can ask about changing medicines. They can fire your doctor or fire someone on the healthcare team. They can hire home nurses. Let's assume you've been in the hospital for a couple weeks. You have run out of your insurance and you have exhausted your financial resources, and you need to apply for Medicaid. Your agent can access your finances to be able to prove that indeed you do qualify for Medicaid. If you need specialized services somewhere else, maybe you might need transferred to a university hospital. That cannot be done unless you give permission to be transferred. It could be that your doctor recommends you go to a rehab facility or maybe even a nursing home. None of those things, I should say it different, all of those things require that you give permission to be transferred. The other thing is really explore with your medical agent particularly if you have very strong feelings about end of life and having CPR, having a full court press to stay alive no matter what. And the opposite. If you are much more determined that there's a point in time in which the good Lord's calling me home, they need to be comfortable with the thought of removing a breathing tube, removing a feeding tube, maybe stopping dialysis, whatever is sustaining you. Because the last thing I think you want to do would be to pick a child as your agent, and the child just comes unglued when it's time to remove these things and mom dies. So it's really important to kind of explore that arena. The other arena to kind of explore is to make sure that your medical agent fixes in their mind what is your goal, because it's really difficult at times. It could be where my goal and your goal are two different goals, and I'm having trouble letting go of my goal to accept yours. So I'm just throwing these things out as kind of information points for you all to kind of think about. So the next big area is how do you figure out that you're incompetent? It's up to your doctor, and it's the same thing we talked about. The doc sits down and explains as best they can what's wrong. And if you don't understand it, and it's clear, you ask a couple questions and you can just tell that they don't understand. What would happen would be your primary doctor would bring another doctor in, and they would both attest to the fact that you're not understanding. And that would be written in your chart. And at that point, that would invoke the medical agent. So that's how that happens. On the backside of that, when the pain medicine is cleared and your mind is clear, your attending doctor says, okay, Ms. Jones, you're awake, you're aware, we're going to kind of shelve the medical agent. You're back in charge. So if you do not have a medical agent and you're in that state where you don't understand, what is the legal system in North Carolina? Well, in North Carolina, your spouse becomes your medical agent by default. If there's no spouse or the spouse refuses, it then goes to a combination of your adult children and your parents. So that could be a somewhat large group. If there is nobody in that group, which there could be, or everybody says, no, I will not do it, then it goes down to the siblings. And then from that, it could go to a neighbor or a friend or someone who really knows you well. And the last level would be going into the court system and getting somebody appointed. So the obvious is if you have 3 kids and 2 parents, you got a group of 5, and it's got to be a vote of the 5, and 3-2 wins. Okay, so it's based on the majority of that group, which could be a pretty difficult situation. Can you do an oral advance directive? Not in North Carolina. You need to put it into writing. So how do you change it? Let's say you do your document 10 years ago, and it's probably not what you want right now for a whole bunch of reasons. So you rip it up, throw it out, and do another one. The thing you got to remember is you got to send the document to all the people that got the original document. In other words, who should get the document? Well, certainly your spouse, your parents, your children, and anybody else that's significant in your life, including your doctor and your hospital. So you really need to spread out the copies. Now, let's say you did that 10 years ago and now you redo it. You need to really send the document back to those same people again, so they have an updated document. And if it really had been 10 years, I'm sure there's going to be some changes there. If indeed you have multiple documents from different times in your life, the healthcare team will take the most recent. So there is a solution to that problem if you get into that bind. Who can revoke it? Only you. So you can do it verbally. Let's say you're in the hospital and you can make changes by just talking to your doctor. You could do a new document. We talked about destroying the old ones and informing the new ones. The other thing to know is there is a ability to do your document, to send them to an electronic repository. So every state has got an electronic repository where they can be sent in and reside. Where should you put it? A lot of talk about putting it on the refrigerator, someplace that's easily accessible to EMTs if they are called. But make sure that it's visible. North Carolina, I found it kind of, I don't know, unusual that in the state of North Carolina, if the EMTs are called, they actually need to see, and EMTs are called, and you do not want to be resuscitated. The document needs to be physically visible to the EMTs. Now, they can use their judgment also, but the really fine, hard definition in your state is they really need to see the document itself. So out-of-state documents are recognized, but you're beginning to go into a gray area that most states recognize an out-of-state document. Like if my wife and I have an accident going home to Virginia, most likely it'll be recognized, but it's not 100% sure that the document has to match all of the North Carolina laws. So if there's things in Virginia that are acceptable that are not acceptable here, it could cause problems, theoretically. But most likely an EMT group will abide by your wishes. The document, once you finish it, it should be not thought of as fixed in stone, that we age, we develop new medical problems, there's other issues, our medical agent has died or is quite ill or moved out of state, or we've had disagreements now with that person. So you need to pull it out every year, probably at your birthday, and look at it again and update it. CPR. Cardiopulmonary resuscitation. So it is only used if your heart stops. Then you can receive it. So if you do receive CPR and you are successfully resuscitated, you're going to the intensive care unit. You will probably end up with more x-rays and diagnostic studies done than maybe you would want, and you're probably going to have a longer ICU stay. So a well-done advanced medical directive, it really markedly improves communication between your family and the medical doctors. That's been very well shown, because you've talked to your family. You know, or they know, what it is that you want and don't want. Depression in family members after someone passes away can be really a major problem. So the Advanced Directive is where you are ahead of time talking to your family and, as best you can, getting everybody on the same page. The other issue that most people have not thought of is where physically you want to pass away. Most of us would prefer to die at home. Some people do not want to. The only point being is, if indeed you do want to pass away at home, you need to be careful about what things you choose to have done in the hospital. More people who do an advanced directive end up using hospice services. So what type of care do you want or not want? It very well may be that you've had some very negative experiences of someone else who had a lung tumor and got radiation and chemo and all sorts of stuff. You may know somebody who was on dialysis. You may know somebody who, for whatever reason, does not want a blood transfusion. So there's a whole hierarchy of things that you may or may not want. If indeed there are some things in your life, you just write them down. I would want this, I would not, I would not. And the same thing with the being put on a breathing machine. Another thing really important is that you know something about pain control. And we have different tolerances. Some people have real high pain levels, some people very low pain levels. so that if indeed you want to be comfortable, you should probably, somewhere in your document, put down your thoughts about pain control. And the reason I say that is, if someone has, if pain you think is going to be a real major issue for you, and you want to be comfortable, it's a trade-off. It's a seesaw like anything else in life. The more pain medicine you receive, the less aware you are going to be of the people that are around you. The other side of that is also you will drink less fluid, you will eat less, and you will probably pass away faster, probably. So it's the balance between pain control and maybe passing away faster, and maybe more or less awareness of your surroundings, who's with you and what's going on. So who can be a witness? You have to be 18 years old or more. They cannot be related to you. It cannot be your healthcare agent or your alternate agent. It can't be people related to you healthcare-wise, your doctor, the doctor's nurse. If you're in a nursing home, it can't be the staff there. And it cannot be someone that might inherit from your estate. The legal healthcare standard across the United States is that if you're found without a beating heart, you get CPR. So the gold standard is everybody gets it. So it's given when your heart stops. So who should say yes to CPR? Or the flip side is, who should say no? So those who should say yes, and by not saying anything, you say yes, okay? So the only other alternative is to say no. So it can be, some people probably remember the New York Jets defensive back, I think 2 or 3 years ago, had a cardiac arrest on the field, was resuscitated, defibrillated, received a shock across his chest, and was back playing, I think, within 2 weeks, I think. So he is the ideal candidate for CPR. So the people who are most helped are those who want to live, really no matter what, and some people do. Those who are younger, those with a good long-term prognosis. If you have extensive disease, lung disease, heart disease, kidney disease, it may be a bad idea. But if you're otherwise healthy, those who are on fewer medications, that is a group of people that really it could be quite helpful. What does successful CPR mean? Most of us, as we near death, it really is a combination of a number of body organs that are failing. It is not like the defensive back for the New York Jets who suddenly had a cardiac event and that was it. So most of us, our bodies are deteriorating over time, and that's what leads to us passing away. So the first CPR, 1959, movies portray CPR as highly successful. What is the reality? So to do CPR, you have to press the sternum down 2 inches, okay? You have to do it 120 times a minute. I can tell you physically, many people struggle to just do the CPR. You have to be physically fairly fit. So you're pushing the sternum and the ribs against the heart, which is pushing it against the backbone, which is pumping blood out. And you've got to be very consistent with it, because if you stop, there's no blood going to your brain. So what are the complications? Well, I'd say everybody gets broken bones, broken ribs, broken sternum. You can also bruise the heart. You can bruise the lung, bruise the liver. You can push stomach contents from the stomach into the lungs. You can get pneumonia. And the lack of blood supply to the brain, you can get brain damage. So survival with CPR depends on why it happened in the first place. If you have a lot of risk factors, it's unlikely it's going to be successful. So what are the success rates? 5% if it happens to you today, now in this room. If you're in the hospital tomorrow, probably more like 15 to 20%. So the other piece of information you need to make a decision is, what is the medical definition of successful? I think most of us would think successful means I'm going to be just like I am right now. That is successful, and that's probably the Hollywood version of it. The actual definition of successful means you were alive when you left the hospital. Doesn't mean anything more than that. You might have severe brain damage. You might have developed kidney dysfunction, a whole range of things. So you have to weigh that as you all make your decisions. So full resuscitation means it guarantees you hospitalization and time in the ICU. So the flip side of CPR is DNR, do not resuscitate. So is a living will a DNR order? The answer is no. A DNR order has to be filled out and authenticated by your doctor. Yes, you participate, but there is your primary care physician involved in this. Like we said, EMTs must perform CPR unless they can see a document. And the living will is not a DNR. It just provides guidance as to what you want and don't want. DNR does not mean no care. You would receive all other care except the fist and the pressure on your chest. So it is a legal document. It is attached to your living will. You discuss it and sign it with your doctor. Scope. In other words, it only deals with the chest compressions and the CPR. You would otherwise continue to receive pain management, comfort care, transportation to a hospital, everything else. In North Carolina, you have to reauthorize your DNR. You do not in Virginia. And the DNR order in North Carolina should be visually present to EMTs. So in other words, you should put it in your purse, your pocket, your wallet, someplace where they could also see it. So if you don't want CPR, do the DNR form. There is one way to help ensure that if you do not want to be resuscitated, you are not resuscitated. You can purchase a necklace or a bracelet. In North Carolina, you should also have a QR code placed on that, because the QR code would link to your document. That way, EMTs could come out, pull out their cell phone, go to the QR code, and immediately see your document and do what you want done. So this is one mechanism to kind of get around some of the pitfalls. Where to get them? Stickley Medical. And I've got the QR code for Stickley if you want it. Now, out-of-state DNR orders. They tend to be acknowledged, but it's not a 100% promise. The best practice would be to convert your document to a North Carolina document. But in an emergency, most likely it would be honored. There are some electronic sites that are nationwide where you can easily do advanced directives. One is Prepare for Your Care, another is 5 Wishes, another is Respecting Choices, and another is Honoring Choices. So those websites walk you through the preparation of an advanced directive. Many times they have explanations. If you check this box, it means this, and you check this box, and it means that. So they provide quite a bit of information to help you fill it out. The other advantage of those documents is they can be electronically stored easily. Let's say you did one 10 years ago, you need to revise it now. You can go into your electronic document, you can change whatever you want, hit save, and then you can actually email it to anybody you want. You can also, let's say it needs to be re-witnessed. You can email it to whoever you want to witness it. They can sign it online and send it back to you, and it goes into the register. So that's going to be the next, I think every state in time will have that. But right now, that's not the case. So really the key part is be open and honest and tell your family, tell your friends, tell your doctor what it is you want and don't want. So we are going to take questions, and I'm sure you've gotten lots.
If you are under hospice care, is that an automatic DNR?
No, sir. It's highly, highly likely that you will have filled one out. Many hospices require that as a part of your acceptance into hospice, because that's a major shift in the direction and, what you want done. My understanding in most hospices, let's assume you have made that decision, they've accepted you, and let's assume you get a pneumonia or you get a bladder infection or you get something that's relatively easy to treat. The hospice would most likely treat you for those things that are really basic. So in a way, the whole business of a DNR is somewhat flexible. It mainly is focused on CPR. In your minds, link DNR, CPR. Those things go together.
You've mentioned a number of documents, electronic documents, online documents, cloud documents, et cetera. Are all of those acceptable if you just hold your phone up and say, here it is in my cloud? All of them, including the DNR?
What is the circumstance you're talking about? What would the setting of that be?
So EMS shows up,
Okay.
and your wife is on the floor, and they say, is there a DNR in the house? And the answer is, well, it's in my phone.
So you would actually have one document in your phone, which you could photograph and put into a special portfolio, at least I can in my phone. So I think the answer is yes.
So they'll accept an electronic, they can view an electronic version, they will accept it and not give CPR.
Yes.
I'm a St. James EMS, EMT.
Yes.
And
please.
I will tell you what our protocol is. It doesn't mean it's going to stay like this, but I'll tell you what it is right now. If we go to your house for cardiac arrest, which means you're on the ground, First off, you're not going to give us anything because you're on the ground, your heart's not beating. We need to, the first thing we're going to do is look at your refrigerator to see if we see the yellow page on the refrigerator. If we don't see it, we will assume you do not have one, which means we're going to do CPR. Then we will ask whoever's around, your spouse, your friends, do they have a CPR? If so, get it for us. If you don't have it, we're going to do CPR. Then when we transport you, assuming that we get you back, which primarily is with an AED, so we're going to shock your heart, we need to take the paper with us to the hospital. And I will tell you my personal experience. About a month ago, we transported somebody to the hospital. One of the other EMTs took a picture of the DNR. We did not take the paper, and the hospital said, we cannot accept, and this was Brunswick on 17. They said, we cannot accept the picture. We need to have the paper. So now we always go around and make sure we have the paper. Might be a little different.
No, I
Virginia.
I really appreciate your comments.
So that's our protocol now. As for looking in your wallet for the bracelet thing, again, that would be a future thing. We have a doctor on staff in the Novant system named Dr. Sherrod. He gives us our protocols. So when we go on scene, usually we don't have anybody who's going to take the time to go look in your wallet. We're going right for your body. We're putting stuff down your throat. We're starting to do stuff on CPR. They're putting injections. They're doing AEDs. So we're not going to have the time to look in there. Again, in the future, that might be a part of our protocol, right? So I'm just telling you what it is right now. And I hope that explains it to you. Because the other thing we'll do is we might open your refrigerator because there are these things called vials of life. And they are lists of medications and your demographics. We really need to know your date of birth and your name, because usually we can get everything else from those two. We'll look in your refrigerator. We're not hungry. We're looking for the thing. Or we'll look, typically a lot of people will have those lists right around the kitchen. So we'll start snooping around the kitchen looking for that. So that's kind of where we're at right now. And again, it could change. I think everything that's here is great for the future because we are electronic. You know, most of us are. But right now we need the paper. Okay? Hope that helps you all.
Would you add a comment about the QR code on the bracelet or the necklace? That's what I came across as I was reviewing for this. In Virginia, those two items are accepted by the EMTs because the way the DNR form is filled out, it's filled out in triplicate. The doctor has a copy, the patient has a copy, and the patient, if he wants a bracelet or a necklace, he sends the third copy to a vendor who is certified to accept that so that EMTs then know those are valid.
Right, you're right. Right now, and I actually wrote that down to take to my supervisors, we don't have a protocol, we don't have a process for looking at a QR code. So I don't know.
Really?
We don't have it.
Okay.
So I don't know what we would do. If a spouse pointed it out, I would certainly take a picture, and then the other people who show up for a cardiac arrest are the law enforcement agents. And sometimes they primarily make sure we don't have 25 people surrounding the patient. I would probably dispatch one of them to go search the records. But again, it's not right now in our protocol, but the protocols do change. All right. Oh, and as for hospice, hospice we go based on the DNR. The difference between what we do with hospice patients and not hospice patients is transport. If somebody is a hospice patient, we're called there, and we do not automatically transport. We will ask a hospice nurse, and that can be from a phone call or something, if we are allowed to transport this patient for this reason. And they'll give us a yes or a no.
Here's the situation. So my wife's on the floor, and I have the DNR in my phone. And they say to me, we're going to need a copy of it. So I push the button, and it comes out. My printer, I hand it to you. You take it to the hospital. Will they accept it because it's not an original signature?
Using that example, if someone, family member's down, phone is here, DNR, the question is, Why did somebody call for help? You're just creating you got to realize you're bringing in a group of people that are going to do CPR, and it's not something you want done. So there's a real indication there.
I have a question. My mother was in rehab, and she coded out, and the rehab wouldn't accept her DNR because it wasn't affiliated. They wouldn't accept her DNR. So do you have to have, if you go into rehab, do you have to check a box that says that your DNR is acceptable in the rehab place? It was a mess.
What I've learned in preparing for this talk is there's a lot of complexity in North Carolina over DNRs and CPR. It is not a smooth process.
Hi, I was a critical care nurse for 40 years. I was the Illinois representative for POLST, which is MOLST here. That is a very important document because that counts on whether or not you would want artificial nutrition, hydration, whether you want a DNR or not, and levels of care. So that helps with the conversation. The most important thing is the conversation, that you've talked to your family. Too many times I would tell a daughter where in the back of the house she would find the forms, and that she was the power of attorney, and her mother never talked to her. So the most important thing is the conversation. But I do know in Texas, someone actually, and I have seen someone with DNR, do not resuscitate, tattooed on their chest. A judge did not accept it because the tattoo artist did the signature. And most surgeons will not take a patient with a DNR into surgery. You got a better chance on the West Coast, I will say. But here, it goes away when you're in surgery because
Legally, it goes away.
I think it's the surgeons that say.
Well, I do understand that.
Yeah,
the surgeons do not want people to die after they've operated on them.
Right.
It goes on to their record.
Yeah, so they will try and make you sign that the DNR goes away. So you have to be careful with that.
The other thing I just wanted to mention, I had a conversation with my physician just this past week about Advanced Directive. I'm not ready for DNR to accept that thought yet. But with Advanced Directive and EPIC, we have these electronic medical records that are now, going national, potentially even international. And I basically said, I'd like to bring in my Advanced Directive. Is there a bucket to put this in where if I go to any hospital that is some way connected with EPIC, will the physicians see it and will they look for it? And she basically said, well, if you bring it into me, the only place that I know to place it is in the documents category. Whether they're going to look among the documents, I'm not sure, but in my mind, if we're using an EMR, that would be the most likely place to put it, especially in one such as EPIC. Do you have any thoughts on that? I guess that's my question.
I think you've outlined it nicely. Some of the EPIC systems talk to each other and some don't.
I went to have my advanced directive notarized, and I didn't realize that I needed to have the two witnesses, but I'm not sure you mentioned it also needs to be notarized. You have to take these people with you.
That's an important correction. Yes, they do need to be notarized.
I think in your presentation, you mentioned that there are certain people who cannot witness a document,
Yes.
and they include the entire hospital. So if you're in a hospital and you're going to write a new one, you have a hard time finding somebody to witness it. It also can't be a relative. And you got relatives, you got hospital people, who's going to witness it? So you got a little bit of a problem if somebody tries to make you do it in the hospital.
Presumably, you're doing it at home and or out of the hospital. I mean, that's the goal.
You referenced a vial of life, somebody. Where can we get those in St. James?
At the fire department at the front door. I just want to repeat it so they get the whole thing. Fire Station 1, thank you. Any other questions?
This is something that's just helpful that we do, and it may help people here. We were talking about putting it in a document and then sending it around, and you may be concerned about someone else getting hold of the document. You can put it in a document, and you can lock the document with a password. You can do this in Microsoft Word. It's actually quite simple. Put the document, the contents of the document in Microsoft Word and lock it. You can also put it all out on a cloud and give access to the cloud to your children and anybody else you want to have the document. That's what we have. We go into those documents in the cloud, we change them to the current situation, and everybody immediately has access to them. They don't print them out. They stay in the cloud, and what they see when they look in there is the current situation. They all know the passwords for all the documents because they're my children, and my wife. So it's easy for them to get at it, and no one else can get at it, and you don't have a bunch of paper flying around being emailed around.
Very helpful. Thank you.
I have kind of a general question. You were talking about the hospital maze. So if you have I went through this with my mom, going to the hospital, you really don't know the people working there, and I don't have a medical degree. Do you think it's helpful to get a patient advocate who has a medical degree that maybe knows to help, navigate these questions?
Simple answer would be yes. Now, whether that person is available, at the specific time you need them, but yes. And something kind of in the same direction you just mentioned. Let's assume you've got a relative in the hospital and there's a lot of controversy about what's going on. You could ask for an ethics committee to intervene and give advice as to what direction to go.
Cyril, I'd like to thank you for the presentation, and it was wonderful. And thank you all for your participation.
Thank you for coming. Yeah.
These are difficult discussions, but it's wonderful to have a conversation, and we appreciate everybody's input, so thank you.